Good afternoon, everybody, and thank you for coming to this workshop. I'd like to thank, first of all, ATHS to have given us the opportunity, as it has done every 2 years, to devote a workshop to prisons. And I'm great pleasure to introduce a panel from various places: Belgium, Australia, Lebanon, France, of course. And we will try and give you a general vision of all the problems that can be encountered in prisons and the different issues that come up, and sometimes wonder why prisons need to be different from the outside world. I think that's what we're trying to do every 2 years in these workshops, and try and bring medicine and care into prisons, which is equivalent to what can be found outside. The discourse is there, the texts are there, but in practice it's difficult. We're going to be having 5 presentations today, so we have to try and stick to the schedule, particularly because we have our friend Patricio from Lisbon, who is going to try and, as a surprise, last-minute surprise, show us his special magic box that he takes from prison to prison. And I hope we have time to do all of this. So I'd ask you all to speak for 15 minutes and leave time for questions, so that we will be able to do everything this afternoon. So we're going to begin. I'm going to hand over to Marie AHOUANTO-CHASPOUL, who for some time was, and she will introduce herself no doubt, but for a number of years she was national consultant in the prison administration, and she'll say roughly what's happened. My name is Fadi MEROUEH. I'm a doctor and responsible for prison health in Montpellier. There are 2 prisons, one prison with very significant overpopulation, almost 200%. It's a kind of a record, and what we call a structure to accompany people who are about to leave prison. It's kind of model institution, so people who are prepared to be better reinserted in society afterwards. I'm also head of a research institute in a prison in Paris. So I will finish the workshop with talking about harm reduction in prison, which is a highly political subject. So Marie, over to you. Good afternoon, everybody, and I'm also going to very warmly thank the organizers of this workshop, because it's a real pleasure to come every 2 years here. The debate is very rich, and also the welcome is fine. And I'd like to thank you, Fadi, for always organizing a workshop around the experience of prison. I have a long experience of working with the most precarious populations. And as Fadi said, I worked for 3 years at the General Directorate of the prisons as a national consultant for prisoners. Now, I'd like to just summarize the different functions of the DAP. There are 5 directorates in the Justice Ministry. The DAP is one of those, and its mission is to follow up and monitor the situation, but also prevention of relapses, of reoffending, and particularly maintaining links with families, and that is a very important element in that for the prevention of reoffending. And the DAP, this directorate, has to work on that for 50% of its time. 50% of its work is supervisory, but 50% is to help prisoners be reinserted into society. But most people who are condemned go to prisons. These are people who have done offences with short prison sentences and are soon going to be out. 50 to 70% of prisoners in France re-offend very quickly, and prisons are both dilapidated and unsanitary, and it is widespread indignity. You have bed bugs, you have cockroaches, the absence of heating, and lots of other things that I don't want to mention. Also, in particular, in harm reduction and sexuality, there is a lack of care and health policies which have to be pragmatic. At the 1st of October, there were 84,311 people imprisoned in France, but there are only 62,614 operational places in prisons. 5,500 prisoners were sleeping on mattresses on the floor. So this means that you're sharing damp cells with cockroaches and mold. 26% of prisoners smoke cannabis on a daily basis. That's 8 times more than in the general population. France is one of the countries in Europe where the consumption of cannabis is the highest. When they are released from prison, and this is the Epsilon study, 2/3 of men and 3/4 of women have psychiatric disorders. This is a study that was carried out on prisons, these short-term prisons. I'm not talking about people who have committed major crimes with long prison sentences. In the month of July, there was a whole effort that was done in terms of helping prisoners to return to society, returning to postal voting for prisoners. This was introduced in 2019, and that meant that prisoners could become citizens, but this was abolished in July 2025. A few statistics which also come from the Epsilon study so that you can see what this population is made up. It's a young population. 70% of them were under 39. Many of them were incarcerated for the first time, convicted to short sentences, and they all have in their experience, 94% of them have had at least one severe traumatic event. Almost 15% of those were sexual assault. There are 8 times more suicides in prison than in the general population. Prison is a single-sex institution, which doesn't exist anywhere else. Schools have become mixed for girls and boys, justice and the army, but prisons in France have remained single-sex. If you look at the prison service, there are 44,200 staff, but most of them, although the direction has this mission of supervision and reinsertion, most of them have a supervisory role, 30,600. And these supervisors are young. They are trained very quickly. It's a 6-month training period, and they're very young. The average age, I think the 188th class had an average age of 28. So there are young prisoners with young prison guards in prisons, and they say that sexuality is forbidden. So the WHO defines sexual health. This is the definition, because this is something which needs to be looked at in terms of a positive, respectful approach without any coercion or discrimination. The important thing in this definition is it's a human right and sexual rights, they go together. But prison sexuality remains a taboo. The DOP, the Prison Administration Directorate, seeks to control every aspect of the prisoners' lives, and I would say almost obsessively. Until 1994, for example, health depended on the Justice Ministry and the prison authorities. It was only separated in 1994, but a lot of habits have remained deeply rooted. Officially, there is no sexuality in prison. It's forbidden. But it is very hypocritically prohibited. They prohibit exhibitionism. It's forbidden to impose obscene acts or acts likely to offend modesty to other people. Prisoners' sexual practices are denied and repressed. The prison administration worked for 3 years on a new prison code, replacing the penal procedure code. And one might have thought that there could have been changes in this review, and the new dispositions are here. The only change with regard to before is that when prisoners go to the commission, the director of the prison could take action. Officers can no longer do so, but the punishments have remained the same and can go as far as 90 days to being deprived of visits and correspondence. These are the punishments, so that you can understand that punishments are severe, because there are a lot of punishments in the legal texts. Up to 30 days in solitary confinement, temporary or definitive loss of visiting rights. So you absolutely need to separate out men and women. The only sexuality that is conceived of by the prison authorities is heterosexual and violent sexuality. And look at what Alain Jamet wrote on totalitarian prisons. And yet sexuality in prisons does exist. You can't prevent young men or young women who are closed up in a closed area from having sexuality. So prisoners maintain sexuality despite prison and in conditions which are unequal and are unpredictable. So this sexuality can either be clandestine in the visiting rooms. Since 1983, visiting rooms do not have separation devices. Prisoners can touch each other. And since 1983, there has been sexuality in visiting rooms. The internal regulations prohibit sexuality among prisoners, and it's also always very hypocritical. You have to have an appropriate behavior, decent dress in the visit, or sexual relations in the visiting room are prohibited. That's a more frontal prohibition. So sexuality in prison generally has three forms. You have solitary masturbation, which I think is more openly accepted for male prisoners, but less so for women. Homosexual practices, which are tolerated in women's prisons, but dangerous in men's prisons. And practices in visiting rooms, which are more or less under the tolerant gaze of prison guards. So this is sexuality which is always carried out in undignified conditions. And the survival strategies necessarily involve transgression and disobedience. So to avoid to talk about sexuality in prison, the prison administration emphasizes the importance of maintaining family ties. So you saw that about 5,500 people who are working amongst the staff on reinsertion and maintaining family links. So the family of prisoners is made responsible for the return to the outside world and a stabilizing force. Each prisoner, and that's the law of 2009, has the right to go to a family visiting room. There are only 54 prisons out of France's 188 prisons that have such facilities, or which are called family visiting rooms. So sexuality which is legitimated, it is heteronormative, and it is the family which is supposed to deal with this sexuality. It is as Fassin said, a compassionate semantic configuration. There are 170 family visiting rooms in 54 prisons. These are little flats with 1 or 2 bedrooms so that you can have an independent life for a period between 6 and 72 hours. And you have closed visiting rooms which have toilets and so on with a maximum duration of 6 hours. There are 128 family visiting rooms in 35 prisons, but of those 35 prisons, 28 also have these short-term flats, so it's very unevenly distributed. It's important to address sexuality in prison because people in prison are exposed to a lot more risks of contracting HIV or other issues. There are issues of drug injection. There are forced sexual activities, the shared injections, limited access or forbidden access to risk reduction or harm reduction processes. Sexual violence, initiated sometimes in prison or before, may persist when people leave prison. And as I said earlier, you can find traumatisms in the past with desire problems, erection problems, and so on. The sex health of prisons is neither recognized nor positively discussed, nor respectfully discussed. So there's a loss of dignity around sexuality. But there may be consensual sexuality in prison, not necessarily violence. For example, 1 person out of 5 in prisons in sub-Saharan Africa have consensual sex in prison. Under French and European law, there is deprivation of liberty, but not a deprivation of sexuality. In French law, the internal rights, something which is not explicitly forbidden by law, is allowed. But for the prison administration, it's quite the opposite. Something which is not explicitly allowed in law is considered as forbidden. And that means that we have problems with the Article 16 for harm reduction in prisons. And that is why we have problems around the deprivation of sexuality in prison. So I think the important thing to remember is that prisoners still have sexual lives, whether it's tolerated or repressed, and that depends on internal control within institutions. And it's very unpredictable because it's the supervisor, the prison warder, who can decide whether it's allowed or not. It's possible to facilitate access to private areas within prisons, and there's an urgent need to increase that. That would limit disciplinary and criminal sanctions relating to sexual exhibitionism. In other countries, there are an increasing number of experiences of mixed prisons, and that began in the 1970s. A country like Spain, which is just moving out from the Franco period in 1975, there are some 20 mixed modules concerning men and women, and there's even a prison in which there are couples with children, young children. In the context of sexual deprivation and repression of sexual practices, particularly looking at the past that certain prisoners have in their experience, I mean that prison officers and healthcare workers are constantly put to the test, not only by others, but also by themselves. Just an idea, prescribing PrEP in prison might be an opportunity to discuss sexuality more easily with prisoners for healthcare professionals, and it can reduce harm. So prescribing PrEP means looking at prisoners' sexuality as well. It's giving them back their dignity and making that humanity that very often is reduced by prison. So it's obviously a little bit more complicated to discuss in prisons, but it is doable. But sexuality of people who are in prisons should not only be approached with regard to the dimension of risk, but you need to give people trust, and you can see the kind of products that you can have which can make life easier for care people in prisons. These are injectables. There's cabotegravir, lenacapavir, and Truvada, which, like all health units, depend on hospital pharmacies. For example, in the Paris hospitals, a box is €3.50, and it's quite affordable. Also, it's important to bear in mind that if you look at sexuality in prisons, you need to open up new areas of research to better understand the health needs of a population which is very often discriminated against and marginalized. And here is a haiku written by Lutz Bassmann about suicide in detention, who says there are really too many people in the cell who can no longer even prepare suicide. So thank you for your attention. Thank you very much, Mali. Are there any questions? We can take just maybe 2 or 3 questions now with a microphone. Thank you. If you'd like to introduce yourself, please. The microphone's not working. There's been the Epsilon study, which was the first cohort study, and the data that I showed you are intermediate data. It's a fairly major study which was done by I can't remember the name of the teams, but it will come back to me. But it was Kevin who was supporting this study. There's an aggravation of psychiatric disorders during prison. As soon as you go into prison, you'll see that there are more psychiatric problems than in the general population. But the conditions of prison life are going to make that situation worse. And it's terrible to see the figures that I showed you. 2/3 of women, and I can't remember for women, I think it was 3/4. It's frightening because we tend to close psychiatric hospitals and to fill up the prisons with people who could be treated differently. So that does raise the problem of penal responsibility, which is, for political reasons, less and less accepted. Normally speaking, in terms of penal responsibility, somebody who is declared as having major psychiatric disorders at the time of the fact should not be in prison. But increasingly they are. I think what's changed, that at the time we're talking about mental illness, people didn't go into prison and it didn't get worse. What is worse is that when the mental state goes worse, they can go into prison. But if the responsibility is considered as being absent, then they don't go to prison. But that was I think it's changed since the 1970s. Before then, it was going to this distinction. So increasing numbers of patients who have mental illnesses are going to prison because we close hospitals for people with mental illnesses. So people who have mental illnesses, those who don't have a family to support them, find themselves in prison. The other thing is it costs less to treat people with mental illnesses in prison than in hospitals. Hospitals are about 500 euros a day, whereas prisons about 150 euros a day. So it's much cheaper to send a patient to prison if they have mental pathology than it was before. No other questions? So I think we'll move to the next paper.
Monsieur Elie AARAJ, qui vient du Liban, qui va nous parler de la situation des prisons au Liban, le rôle des organisations de la société civile. Elie, à toi.
Oui, bonjour. Fadi m'a demandé de me présenter. Donc, je suis Elie AARAJ, je suis le directeur exécutif du réseau Moyen-Orient-Afrique du Nord sur la réduction des risques, Middle East and North Africa Harm Reduction Association, basé au Liban, à Beyrouth. Et je suis président fondateur de l'Ordre des infirmières et infirmiers au Liban. Et là, on va parler de la situation des prisons, mais aussi on va focaliser un peu sur la situation de la prison.
We're going to focus on the prison, the central prison of Roumieh. You can see in the photo here. It's the largest and most famous prison in Lebanon. It was designed at the end of the 1960s and inaugurated in 1970. It was intended for 1,500 prisoners, but currently there's overcrowding with over 300%. So the prison is is located on a hill in the east of Beyrouth, in a village called Roumieh. And with everything that's happening at the moment, this prison still does not satisfy the minimum criteria fixed by the UN. There's overcrowding, extreme overcrowding, a lack of basic medicines, and a lack of hygiene, and also healthcare. So this has led to a large number of deaths in the prison. For this question, we talk about a lack of basics, because overcrowding is over 2.7 times the number of detainees planned for. In some prisons, There's very poor in facilities. Water quality is very poor, which leads to infections, to illnesses. There is a generalized lack of basic medicines and hygiene and food, and very limited healthcare. And there are some prisons, there are no doctors, no nurses, no medicines, there's no qualified medical services. In others, given the economic situation of the country almost went bankrupt. Sometimes somebody who has a heart attack or is ill, the internal security services, the prison guards, don't have the means to take them to the hospital, and so this leads to people dying. So there's a lack of health care, and to make things worse, there was an increase in the number 2022, 34 people who died in prison due to a lack of medical care. So this shows that the system is a systemic failing of the system. This increase is due to several factors: the economic crisis, and also the lack of staff, health staff, and the negligence on the one hand by the government, and the other hand also by the families. The organizations in charge of human rights at Amnesty International, Human Rights Watch, have always pleaded for a total reform of Lebanese prisons. As we've said, the standards in present in Lebanon do not comply with international standards, such as the Nelson Mandela rules of the UN. So in terms of the social society of the last few years, there's been a group, a working group, with civil society organizations, more than 25 associations who work in this field. And what they try to do is to think strategically about how we can solve this problem and come up with a reform of the system. We created and create an emergency fund for people who need medical attention. But at the same time, we're trying to mobilize things within the country for courts, sentences, and the prison staff. Lebanese prisons are under the Ministry of Interior and not the Ministry of Justice, and are policed by internal police forces. The gendarmes are unable to even make a living from the jobs they do. So we went to see the Director General and said, we're here to accompany you. He just simply said, well, we need your money to pay their salaries. If we're unable to provide a living for the policemen, how are we going to take care of the prisoners? So there's all these different problems, and this plays a role in the lack of human rights in Lebanon. The associations who contribute to improve the conditions in prisons and to defend prisoners. To help them, There's legal assistance, which is given by lawyers, and sometimes we try to go to see the order of lawyers for certain services or for advice. This is free of charge. We try to encourage rehabilitation and reinsertion in society. This includes vocational training, education and social support to facilitate the prisoner's reintegration in society after release. And we also try to provide humanitarian assistance, including food, medicine, hygiene products, and these are often very rare due to a lack of negligence by the state and various economic crises. And there's also psychosocial support made available. We try to plead with the authorities. We try to work as an observer to document any violations of human rights and to increase awareness within prisons. We draft reports on conditions of prisoners, torture and other abuses based on data collected during prison visits and accounts. We also try to pressure the government into reforming the penitentiary system, and we try to interact with ministries, political leaders and other stakeholders to promote policy changes and the implementation of reforms which comply with international standards. Many civil society organizations collaborate with both national and international organizations, governmental agencies and even the prison authorities to achieve these objectives. There are challenges ahead, of course, in our work. Sometimes these organizations find that there's a refusal to provide them access in prisons, especially when there are problems, strikes, hunger strikes by prisoners. Organizations were refused the right to access the prison. The overpopulation, which is a major issue. What we know at the moment is that more than 60% of prisoners in Lebanon are not Lebanese, they are foreigners. More than 85% of prisoners are have not been sentenced yet, and secondly, and don't have access to legal assistance. And third, more than 60% of prisoners are from crimes related to drugs. So there's all the social stigmatization which goes with this, and means that it's difficult to obtain a great amount of support for the reinsertion. And in terms of bureaucracy, there are prisoners who've been there for years and have still not been sentenced yet. During the COVID years, as an association, we carried out parallel work in Lebanese prisons, the Roumieh prison, with the Justice and Miséricorde Association. We were working in Jordan with Land of Peace. We organized mental awareness sessions, counseling, and provided hygiene products. We also tried to make them aware about COVID itself. And last year, because of the war in Lebanon, there were prisoners who had to be displaced. They had to had to go from the south, prisons in the south, to the north of the country. And this is another reason to explain overcrowding in prisons. We were asked to provide mattresses and quilts. The social society organizations are essential to protect human rights and provide essential services within the difficult context of Lebanese prisoners. Despite the obstacles, they continue to play a crucial role by pleading for reforms and promoting a more human and fair prison system. Perhaps you might say, why the civil society? In some countries where there are systems which work, where the government takes care of the people, you perhaps don't need civil society to help. But in a country where the system is on its knees, the work of civil society began many years ago, and this increased during the civil war from 1975 to 1990. Lebanon needs reform of its prisons. This should be placed under the jurisdiction of the Ministry of Justice and not the Ministry of the Interior, and not managed by interior security forces. We need a health strategy for prisons, which includes risk reduction services, and this should be adopted. Vocational training programs for prisoners with activities which generate revenue. These should be implemented and applied. And we need to accelerate trials so as to reduce, wherever possible, the prison population, prison overcrowding. Thank you very much. If anyone would like to ask a question. It's just a reflection. I'm from Belgium. Civil society can always intervene in prisons, whatever the country. It doesn't matter whether the government is present or not. There needs to be a permanent monitoring by civil society of what's happening in prisons, what's happening to the prisoners, and how the prisons work. Even in France, NGOs can take part. And for hepatitis, seed action, it's extra help. And very often, carers can't be trained in everything, in every speciality. So perhaps 90% of prison wardens don't know what PrEP is. So very often, we need training from outside, so we need associations to be present. But it must always be complementary and not to replace, as is the case in certain countries, to replace the government. Luckily, there are associations there to provide help. Let's now turn our attention now to Adrian DUNLOP, from Australia, who's going to talk about. We often talk about people leaving prison, but not necessarily about addiction and treatment. There aren't many publications about this. Sometimes, once the prisoner have left prison and they're receiving treatment, we know what happens when they come back into prison, but we don't know what's happening when they're out of prison. But here it's a study which is very interesting for us to see if the work done in prison bears its fruit outside of the prison.
Bonjour, je m'appelle Adrian DUNLOP, un spécialiste en médecine addiction de l'Australie. Merci pour l'opportunité de parler.
So thanks for the opportunity to talk to you today.
about a study of patients coming out of prison in Australia. I'd like to start by acknowledging that this work was conducted on the lands of First Nation Aboriginal people in Australia. It's important to acknowledge this because this group is very overrepresented in custodial settings in Australia and has bad outcomes. The organisation I work for has received funding from both Cameras and Indivia. So just to start, the early information on both observational and experimental studies looks like the retention in treatment for patients commencing long-acting buprenorphine is probably similar to methadone and buprenorphine. And that's the basis of the study that we're looking at. We're interested in retention in treatment on people coming out of custody. So to quickly summarise the literature, any transition for a patient is risky, and the transition of coming out of prison is a particularly risky period with a greatly elevated risk of fatal overdose, both early but extending up to 1 year and longer. Opiate agonist treatment is associated with a reduction in drug use in prison, a reduction in injecting in prison, a reduction in overdose risk both in prison and after release. Opiate agonist treatment in prison is associated with increased engagement after release, decreased drug use after release, and decreased reincarceration. So the evidence base is very strong for opiate treatment. It's important that opiate treatment is continuous, it's not stopped and started, and we should also recognise prison is a good opportunity to provide opiate agonist treatment for patients who aren't already in opiate agonist treatment. There's 3 early reviews of the effectiveness of long-acting buprenorphine in custodial settings. All of them suggest, without being definitive, that there may be some advantages of long-acting buprenorphine, particularly in terms of retention in treatment. However, there's also a large cohort study from the US, nearly 60,000 patients, non-randomised study, which looked at mainly patients on sublingual buprenorphine, but also a group of patients on long-acting buprenorphine, and they found much poorer retention with patients on long-acting buprenorphine compared to sublingual. So it's an important area we study. Our group previously did some work on safety of long-acting buprenorphine in prisons. It was a group of patients who weren't already on treatment who were offered long-acting buprenorphine. In summary, retention was good, adverse events were common but mild, we didn't detect evidence of diversion attempts, patients were highly satisfied, not surprising because they weren't already getting treatment and they were then offered treatment, and interestingly, it was strongly supported by correctional officers. So we saw a great reduction in non-prescribed opiate use during the period of the study. But importantly, we also collected some health economic data, and the costs in prison of providing the treatment, that's not just the medication, but the staff costs, so the health costs and the prison officer costs in Australia are much, much less of depot buprenorphine compared to sublingual buprenorphine. So that's about €80 a month for staff costs for depot buprenorphine. It's 10 times that for sublingual buprenorphine. It's about 3 times that for methadone. So we did this work just before COVID, then COVID happened and there was a need to scale up treatment very rapidly in prison. It's important to point out that prior to this time, patients who were already on methadone treatment and were entering prison remained on methadone treatment, but if they were not on treatment, they were not offered any treatment until just before their release, which is poor policy and poor practice. However, once COVID started, we can see the grey line is the increase of the number of patients on long-acting buprenorphine from not many to over 1,400 in a 2-year period. Now, at the same time, depot buprenorphine became more prescribed across Australia. So you can see the blue line is the number of patients across the nation prescribed long-acting buprenorphine, and it starts to exceed, by late 2022, the number of patients on sublingual treatment. And indeed, The pattern with methadone is that methadone used to be the predominant treatment. It's now no longer the predominant treatment. So the dark blue is patients on long-acting buprenorphine, the orange is patients on sublingual buprenorphine, and the grey is patients on methadone. So now more treatment with buprenorphine, and the majority of that now is long-acting buprenorphine. Importantly, in prisons, the majority of treatment in prisons has become long-acting buprenorphine as well. So you can see over 90% of all of the treatment in prisons across the country is now long-acting buprenorphine. So with this, we were able to get funding from the study from the state government to study the outcomes of patients being released from prison. I'd like to acknowledge the co-investigators, including Dr. Nick Lindsay-Ross, who's here in the audience. We did 5 sub-studies as part of this study. I'm going to talk to you about the first 4. So we did administrative data collection of all patients released, and then a sub-study of some patients that we followed up and interviewed in detail, a qualitative study of some patients that dropped out of treatment, and then also focus groups with clinicians. So the study included all people released from New South Wales prisons over a 12-month period. It included patients going to treatment clinics in 80% of the state, so most of the patients in the state. It was a non-randomised comparison of patients being released on methadone and buprenorphine, long-acting buprenorphine. The outcomes I'm going to talk to you today about are retention at 3 months. So there's the 12-month period, and there was an additional 3 months for follow-up. The definition of retention for patients on methadone was to have a dose at least no longer than 2 weeks apart, and with long-acting buprenorphine doses at least 8 weeks apart, not longer. In summary, the patients were around late 30s in age, 90% male, generally in rental accommodation. About a third were Aboriginal. Most of them were on social insurance for income. Most of them were referred from the justice system, although there was about 10% that were self-referred. The majority in major cities, but 17% in rural Australia. 83% of occasions the referral was expected, that is the release was scheduled, was planned, and 87% of the time it was from a public prison. So the primary analysis is where we have dosing information, where we have a record of the patient receiving their dose, and that's how we define retention. However, it doesn't cover all patients. So some patients might be referred to a clinic but never get to that clinic. They go to another doctor, another prescriber, or they're treated in a community pharmacy. So there's 2 other assumptions of retention in treatment. The first one is the strictest. The second one is where the patient attended the clinic at least once and then went elsewhere, and we were able to verify they continued to get dosing. And the third one is they never got to the clinic, but we were still able to confirm that they went somewhere else to receive treatment. So 3 definitions, and here are the results. So we had 1,100 patients on long-acting buprenorphine. You can see the strictest definition, 70% of patients were retained. On the less strict definition, 71 to 77% of patients were retained in treatment. To look at the associations with that retention. Retention was worse if the patient came from a private prison, about 10% worse, and if the patient wasn't expected to attend, then they were more likely to attend. It sounds confusing, but it means if patients were not expected to be released, they were more motivated to attend for treatment. Then of the patients on methadone, you can see with the strictest definition, 66% were retained. However, using the other 2 definitions in terms of contact, you can see it's between 85 and 91%. So a much larger range there. There were no associations that were significant in the methadone group. It was much smaller, 327 patients. And just to give you an idea of the doses were all adequate doses. So you can see the mean dose of Buvidal was 120 milligrams, the mean dose of methadone was 92 milligrams. We didn't attempt a statistical comparison of the patients on long-acting buprenorphine or methadone for multiple reasons, including that they're different populations. So one of the SUD studies where we had more information on patients after release, we were able to interview them after release. This was of 305 patients, followed up 12 weeks after, most on long-acting buprenorphine. You can see the group on methadone is a little bit older, about 5 years older. They're more likely to have been in custody before, but both groups are very likely to have been in custody. They were in treatment they were in custody nearly 2 years longer. They had more overdoses. The group on long-acting were more likely not to have been in treatment before, and 2/3 started treatment in custody. So a younger group on long-acting, less time in custody, and more likely to be opiate naive or starting treatment at that time. We then did this qualitative in-depth interviews with 31 patients who stopped treatment to try to understand the reasons for them stopping treatment. 24 were male, 16 were Aboriginal. 26 of these commenced treatment in custody, so treatment was new to them, and 15 had never been on treatment before. And some of the key themes, I won't go into a lot of detail, was unfamiliarity with the medication, being told things about the medication that probably weren't accurate, but that's what they were told and that's what patients believe. So for example, being told it wasn't safe in pregnancy or it didn't work properly. Other reasons including changing situations, so needing treatment in prison but not needing treatment to the same degree when they were released because they had access to drugs or they didn't want to continue treatment. And also some of the challenges, just the physical challenges of going from custody into the community, meeting people that they'd met before that were using drugs that they didn't plan to, being in an unstable environment, etc. When we talk to clinicians, it's maybe not surprising, but clinicians said we really need to focus more on patients coming out of prison on long-acting buprenorphine who have never been in treatment before because they've never made this transition from a prison to treatment in the community, and there's more opportunity for them to drop out. If a patient's on methadone, after 1 or 2 or 3 days, they're in withdrawal, they need to attend for treatment. A patient on long-acting, they can go much longer periods of time and may not get significant withdrawal. So, to conclude, it's great we've had a rapid upscale in treatment. There was a very significant amount of under-treatment before, and that's improved. It's about over a 3-fold increase in treatment, treatment penetration in prisons. However, there are still gaps in treatment. Some differences in retention of treatment at 3 months, 70 to 77% with the long-acting group, 66 to 91% with the methadone group, but there are multiple reasons for this. Different populations, but it may also be the different characteristics of the drug. As I was saying before, it's easier to stop long-acting buprenorphine and not get a sudden opiate withdrawal syndrome, whereas it's impossible with methadone. And clearly there's opportunities to develop strategies to better enhance retention, especially for patients who are new to treatment. Multiple factors impacting on dropout, and they include issues of knowledge, support, and structural factors. So some key issues in Australia. It's important we improve patient education on patients, especially new patients starting treatment, including side effects, about access and about community supports, targeted education information, particularly to populations, important populations like First Nations people, and the need to continue to upscale services. Thank you very much.
Quelques questions.
So I can take a few questions if you would like. Thank you very much, Adrian. Good afternoon. Thank you very much for your presentation. I work in Marseille, where we're trying to promote harm reduction in prisons. Excuse me if I'm ignorant, but I don't know the difference between private and public prisons. There were 2 types of prisons in your presentation. What is the difference between the 2, and what does that involve in terms of access to treatment? Because we had some fairly significantly different results. Thank you.
Thank you for the question. So, most of the prisons in Australia, in the state of New South Wales that I'm from, are public prisons. They're owned by the government, they're operated by the government, it's government health staff, the Ministry of Justice or the Ministry of Health provides the health services. However, there are a number of prisons that are private prisons. They're operated by a private provider. There's a contract between the government and the provider to run the prison, including the health services. The level of oversight is poorer. The level of information from the private prison to health services, for example, is much poorer. And in fact, it's a disaster to the degree that the government is starting to buy back the prisons from the private operators. However, the biggest one has a 30-year contract, and so the government won't break that contract. So it's not a good situation.
Bonjour.
Good afternoon. My name is Louis Philippe. I come from Canada. Thank you for your presentation. It's very interesting. I have a question, a technical question, really very specific. But from memory, you said that your cutoff point to determine whether a treatment had been stopped or suspended was 8 days. Is that correct? Why did you decide that that was going to be the cutoff point and that it was 8 days, so that a treatment should be considered as having been interrupted?
So it's another good question, and I should point out there's some differences. It's very hard to compare a medication in terms of retention that you receive every day compared to a medication that you can receive once a month. So the definition for methadone was for 2 weeks. If a patient hadn't had a dose for 2 weeks, then they were not retained. For long-acting buprenorphine, the definition was 2 months, because you can easily skip a month and continue treatment. It's a good criticism. It's comparing apples and pears. It's not the same comparison, but there is no standard agreement on what is clearly no longer retained in treatment in long-acting buprenorphine. That's the one we chose.
S'il n'y a plus de questions, on va passer donc à...
So if there are no more questions, I think we'll go to Belgium.
qui est plutôt...
Let's hear from Kris, who is a militant who has been trying to get RDR into prison for several years. Don't lose motivation. The floor's over to you. Thank you. Hello to all of you. Thank you to the organisers of this magnificent Congress. It's the first to me, the first time in Biarritz. I hope it won't be the last. I'm from Brussels. I run a crisis management centre in Brussels. We do. We welcome a lot of people coming out of prison. So I come from civil society. My presentation is going to obviously be going to reflect that and show that we have a dysfunctional system. I have a few Belgium and Brussels colleagues from Brussels and Belgium. 10 weeks ago, I had to do this presentation in front of the representatives of the prison services. I'd like to give you a few key elements of my presentation. For 20 years now, I've been able to see inside and outside of prisons what's happening. There are certain things that have happened or not in Belgium, so I wanted to it's not huge progress, but there's a certain number of things which need to be criticised. If we look at the last 10 years, 11 years ago, we asked for a transfer of jurisdiction because in Belgium, prison health care is the Ministry of Justice. We asked for this to be transferred to the Ministry of Health. And so, for example, when we try to reduce risks, the problem is that we keep the obstacle is the Ministry of Justice, and this is still the case today. There's a whole series of precepts, like in France, which are very rigid. An old law from 2005, the Law of Principles, which tries to transpose the international recommendations. On paper, this exists, but for 20 years later, it's still not been enforced correctly. So there's 100 articles or so, and this is these have been voted, but the articles about health have not been enforced. This is regularly a major concern. What's interesting in Belgium is that the Ministry of Justice, Health, and the healthcare insurance system refer to the KC, a study to take stock of the situation in Belgium, how much it would cost as well to transfer this jurisdiction. In 2014, there's a movement. The recommendations for the KC study, and it's there's an injunction forcing Belgium to transfer the jurisdiction, but overall, nothing has been done so far. That doesn't mean that there's been no discussions, but globally, we're still at a dead point. There was the initiative for public health with the introduction of a series of pilot projects on drug-related issues in prisons. It was a fabulous opportunity, 10 pilot projects in 10 prisons out of the 35 we have in Belgium. It was interesting. It was a model. The problem for these pilot projects is that it didn't lead to a federal change. There was, in the big cities, I'm talking about Brussels, there was a huge amount of crack, not just Brussels, and it didn't stop at the walls of the prison. And so we were able to hear that more frequently, perhaps with less taboos, prison directors complaining about the presence of drugs in prisons that have been omnipresent, always been omnipresent. But given the crack crisis, the directors gave us they were able to break the taboo, and so we're able to talk about this. In Brussels today, we haven't had a Brussels government for 502 days now. We laughed a few years ago when there was no federal government, but life doesn't change when there's no government. And this means that for subsidies, projects are stopped. Associations no longer receive subsidies because governments stopped. And our financing is very precarious. What's interesting for us with this, with the fact that we're all fed up with the situation, we have been able to create a project to reduce risks, which had been dormant because of COVID. I'll explain this a little bit later on. The reason I want to present a new network, which is called Unlock, and which was driven by Fadi during a night session in the streets of Paris. As I heard about this project with Fadi, and so a few months later with the partners, we went and looked for the associations, our friends in Brussels, to create a network. Here you've got a centre of you've got different associations in Brussels. It has to be a network of associations, not a network of people. I've seen too many people be attacked by the system, so that's why we need associations to do this and not people. This gives them a certain amount of anonymity, and of course we're more efficient when we work together. The idea is to be as many as possible, so that we can avoid being attacked by the Brussels government. We have some motivated doctors known as MDMA, dynamic, militant and anonymous doctors. There are also nursing staff who are more discreet in this network. The calendar led to the second phase. We were able to organize an event and develop the three main axes of this network. We wanted to bring in equipment into prisons to be able to test, to do testing. We've got no figures, and treatments are not implemented in prisons because either prisoners not in prison long enough, or there isn't the financing. It's also important for us to implement training and to what we've planned with prison wardens. So the idea was to go with our Brussels partners, trying to get partners in Wallonie and Flanders, the other regions of Belgium, to try to bring them together. At the moment, it's working well. Dominique is here with us, and their help is precious. And with the Flemish, we are finalizing a document at the moment that needs to be translated. And so we know that the Flemish will also join us. We want a national network with associations, different federations from these three regions, and to have greater strength against the government to get things moving. We have a very naive and very utopic vision of things, but we really believe in it. And we also supported by Health Without Barriers on a European level. Concretely, what we want is for the health of prisoners to depend on public health to unblock certain situations. We want to refuse a lack of transparency. It's almost censorship is almost systematically implemented. That's been happening for the last 20 years. There's a wish we haven't given up, and this is something that is part of our professional DNA. We want to follow up collaborations between external services, doctors, and internal prison services. And I think this is the medical service, the wardens. These are the people who we have to work with. And also continue to help adequately those incarcerated, pragmatically. And a former French prisoner who came out a few years ago has wanted to drive this project. It's called the Proud Project. Usually the French are #1 in acronyms. It's project for the information on reduction of risks, and it's a term which could be used here. We add the E for exchange of material. Here we have Mathieu, who is from the Pirate Project. So it became a private joke. We want to go from door to door, from cell to cell, to talk about overcrowding in prisons. And this is want to have a true dialogue. We'd like to one day be able to go in with equipment and help the medical service. Here there's a convergence of different life forces, systems which are focused on SH, We have a modus partner for prevention, hepatitis C, a network. It's a convergence of the shared knowledge, which is our force. And each of these associations will delegate work so that on Saturday afternoons they can go and work on in prisons. I'd like to thank all those volunteers for doing so. The objective for us is it's perhaps not the best solution, it's just a lever. It's a lever to get through the door, to reassure wardens and that certain things can't be used as arms against them. And once we can get them actually working together. We have a Canadian colleague who talked about strategy of awareness and understanding the way wardens think together. It was a good idea to help we continue this pilot project in other prisons. We go twice a month. We've not been able to go for the last 2 months due to lack of money, but the idea is to gain the trust of other management, work and try to collaborate with prison wardens. And once we get through to them, we know where we're all going. We've had no problems. And I hope one day we will be able to implement this in prisons. I went into a meeting with this pipe, and I was able to get this pipe in. And I actually said to the director who touched it, there's fingerprints were on it, and so he was rather embarrassed. He didn't laugh much about it, but it was to show what could happen. Please support us. There's a QR code down here. Even if it's from France, all support is welcome, and I hope we'll be able to discuss this more during the coffee break. Are there any questions? We haven't brought any T-shirts with other T-shirts with us this year, unfortunately.
Si ça marche. Merci de me donner.
Thank you very much. I'm still Fadi MEROUEH, I haven't changed. But I don't have my presentation. I'm going to be talking about harm reduction in prison, and I've called it France confronted with its health sacrifice. I'm going to show you that harm reduction is legal in France, even though the administration is not happy. The people are trying to forbid harm reduction, and I'm going to give a demonstration that harm reduction does exist in France. It can be done legally. The only problem is that it's no longer the prison administration that can stop it. I think that it's often the case that people don't want to do it or don't know how to do it. When we're talking about harm reduction, the French say risks and damage reduction, it's actually a universal approach in medicine. Harm reduction has always existed. Vaccinations, for example, is reducing the risk of infection. When you give nicotine substitutes, it's to reduce the risks connected with tobacco. When you wear a back truss or back support, it's to limit damage to your back without dealing with the cause, but it just reduces the harm. In surgery, you sterilize the instruments to reduce infections. On cardiology, it's the same. It's the same. Reduction in medicine is everywhere. In France, we say it's better to prevent than cure. And not only, of course, in medicine. In other professions, engineers have invented airbags and seat belts to reduce the number of deaths on the roads. Architects in some countries have anti-seismic standards, and IT people have firewalls and antivirus protection. So we try and reduce risk as much as we can. It's only in addictology that it seems to raise a problem, and I can't see why. So there's this universal logic of care, protection, and innovation. And the official definition of harm reduction is attempting to reduce health and social risks connected with the consumption of psychoactive substances without necessarily demanding immediate cessation of consumption, nor denying the sometimes illicit character. So that's very clear. It's risk reduction, harm reduction. Now, why in prison? Why should prison be an exception? Why are we talking about harm reduction in prison? Because we're talking about this idea of an equivalence, and we're talking about ethical healthcare. It's in the law. Healthcare should be equivalent to those in the community. That's what the ministries say every time we see them. Even the WHO has defined prevention as actions to reduce illnesses, accidents, and handicaps. So if we look at the three forms of prevention that we learned, there's primary, secondary, and tertiary prevention. Primary prevention, if you look at addiction, it's avoiding consumption. So, of course, you could start by doing primary prevention by education in school, raising awareness, and so on. Secondary prevention is going to come in early to limit dependency. You can have screening and advice and so on. And tertiary prevention is accompanying people who are now dependent to reduce harm. And here we can have substitution treatments and therapies and so on. So addictology has harm reduction like healthcare or any other health issue. We have a solid legal framework. That's the first thing to say in France, is that the law of 1994, we always need to refer that, is transferring prison health to the public hospital service with a fundamental principle, which is equal access to healthcare, and that was voted. A decree in 2005, sometimes we say there is no decree. Very often people say this, that there is no decree. But we do have a decree in 2005, which is the only decree in France in 2005 on users, on harm reduction for users wherever they are. And we see the decree is very well drafted. Also, the prison law of 2009, which again talks about the principle of equivalent healthcare. It's very good for us that the prison law recognizes the equivalence of healthcare, and the most recent law, 2016, modernization of the health system, which is strengthening prevention and harm reduction in prison. And very often people say there is no decree. The law was voted in 2016, but we're almost 10 years from the vote of the law, and we don't have the decree of application. But let's go back to 2005. It's a decree that you can find in the official journal, and it describes the distribution of prevention material to prevent transmission of disease and so on. And on the point of intervention, it says that they should go everywhere in public areas that have frequented by users. You can go into the streets to do harm reduction. You can go into green spaces, stations, and so on. But it didn't put prison in, but it put etc. So etc. might imagine everywhere where users can be found. So this is an official decree which enables us to do harm reduction. And we have a methodological guide. When health went under the Ministry of Health, they produced a guide which the Ministry of Health and the Ministry of Justice together, they sat down and they wrote what we should be doing and how we should work in prison. And on the risk or harm reduction aspect, they say that they don't want exchanges of syringes, but they want to give bleach so that they can clean used syringes. So the prison authorities recognize that there are used syringes, but rather than exchanging syringes, they give bleach, and they explain how you do that. You should rinse the syringe 3 times with bleach, 3 times with water before you reuse the syringe. So these are good use practices for syringes, but at the same time, they're right at the top, but that's not enough to eliminate infection. So you give you the bleach, but they tell you that it's not enough. And nice thing, you were talking about what is implicitly, what is written and what's, you have to read between the lines. But the distribution, it says, of syringes which are not distributed by the health services is not allowed. So syringes that are given by the health services are allowed. If you have neither, it means that you can. And the Minister of Justice also writes that you can do this. There are quite a lot of things that are written by the administration. We also have a regulatory framework. That's interesting too, because there's the Public Health Code. And this Public Health Code, I'm not going to quote all the references, but it is that hospitals are responsible for healthcare and prevention. Hospitals are responsible. The coordination of prevention should be done with the prison and the regional health services, the regional health agencies, and that the state should ensure the safety of healthcare professionals in prison. So the principles of equal access, prevention and continuity, and that there is a right to care that is appropriate, safe and recognized. So that's clear. So there's also Article 3411 says that you have to make available prevention material and prevent infections, overdoses and complications. And even if we come back to 1996, the first Health and Justice Circular, 96 was AIDS coming into prisons. There was contaminated blood transfusion, so on, quite a number of scandals. And this recognition already required risk reduction actions by an exchange of sterile material that was in a circular. But when they say that it's not a law, it's a circular, but it's written in the circular. In France, it's a law, a decree, and a circular in its order of priority. So the message, I think, is key for me. It's clear. Prisoners have the same health rights to harm reduction as anybody else in society, and the prison administration must guarantee safety and the conditions which enable these rights to be effectively delivered. So we spent ages talking about this. We've had working groups. We were invited 15 years ago, even some Swiss people to come. The director of the prison in Champs-Élysées came along to talk about this, and he said, as the director of the prison, he asked for exchanges of syringes because he thought it was much better for the staff. So a lot of people have come in to give their account of what was doing, but we have to go back over and over again. But in 2024, very recently, a number of French associations, SIDAction and others, AIDS, and so on, a lot of associations complained against the Prime Minister, the Minister of Health, saying that those ministers hadn't implemented the law of 1996. The Council of State responded. It refuted the fact that you cannot lodge a complaint against the Prime Minister and Minister because they said, yes, the law is applicable. And the Council of State, looking at various points, recognized that the law was there, looked at the points in the law, and said the result is that today you do have a right. The decision is there. I'm not going to read everything. The result is that you can, in prisons, do harm reduction. The interesting thing, it doesn't mean that the application of this policy will depend on prior authorization. So you don't have to have a decree because the law has been voted and therefore it is applicable. And it recognizes the harm and so on. So we don't have to wait for the law. So if I had to go back to this text, I don't always understand what law people write, but I asked some lawyers to explain. It says that harm reduction does apply to prisoners. There's no need to wait for a decree to apply it. The law is directly executable, and professionals who do harm reduction in prison are covered by the law, so there's immunity. You can never be taken to court or accused of taking part in harm reduction in prison, and are also protected by 122-4 article of the Penal Code, no penal responsibility if you do harm reduction. So we really have all the keys in our hand, and yet it doesn't work. So why don't we not have harm reduction in prison? I'm going to go quickly about. There's no doubt that there are drugs in prison, no doubts about the practices in prison. There's been a lot of information to suggest that you can get just about whatever you like: cocaine, heroin, cannabis, methadone, and so on, whatever you want. This is something we can see in all European prisons. You can see practically the same thing. And I'll show you a European study shows that in all European prisons, when you look at the wastewater, you can find high levels of drug use. So we don't need to provide any evidence. This is the EU, which carried out this study with the MCDDA, looking at all the drugs that are circulating between cannabis, cocaine, amphetamines, and heroin. Sometimes important countries, they all have their different habits. But what you see in civil society is something which you can also see in prisons. That you can also see, just as an example, cannabis in prison is up to 87% of the prison population, whereas it's a maximum of 45% in the general population. Cocaine is 7 times more, amphetamines practically 6 times more, and heroin is almost 30 times more. So the consumption of drugs in prison, you don't need to prove that it exists. And today, in a lot of European countries, you go to prison because you've been, there has been substance abuse, and it exists in prison. Injections in prison has always existed. We can see when you go to certain countries, studies have been done, and people who injected before imprisonment continue to inject during imprisonment. And if you had to give some examples of the consequences of these injections in prison, it's also hepatitis C, HIV, and so on, which are much higher than in the population outside. And not only in France, if you look at European countries with here HIV and HCV and hepatitis C, you can see that in all of the countries, the increase and the prevalence is very high, depending on countries. And you can see that between the population in prison on the left and you look at drug users, you can see that the prevalence is 10 to 20 times greater. And we also know that if you don't treat, you don't give care in prison, then somebody goes to prison, will know precarity, we know what happens inside prisons, promiscuity. We're talking about mattresses on the floor, 3 or 4 people in a cell, that just increases contamination. And when it recontaminates outside, there's a public health dimension that has to be borne in mind. That is, looking after healthcare in prison is not just care within the prison, but it also represents care in the much wider community. You have the 15 points that were edited by the United Nations, which were considered as the 15 points that you have to have in a prison, signed by all the countries who signed a convention with the UN, and that includes France. I put it into French very quickly. That's information, education, and screening, and everything else that we've had here, because we can't stop and say, if we're doing harm reduction, we can't just stop with crack pipes and exchanges, but it's the whole range of harm reduction that we need to talk about, including vaccination and so on. So starting out with this principle, I've been working in prison for 28 years now. It took me 14 years I've been asking questions about how you could improve care for patients. We decided to implement the 15 points that we saw there a moment ago. We're beginning with information. In all the offices, we have flyers to inform the population about diseases, tuberculosis, HIV, and so on. We have, in all of our offices, we have condoms to respect the WHO rules. We do screening because in prisons about 80% of people know their serology. So sometimes because they knew already and so on. We use HPV, we use tests, we're using blotting paper when we can't get into the veins. There's a treatment for methadone and Suboxone and Buvedone, which is about 70% now. We also give treatments for HIV and hepatitis B and hepatitis C, and we also propose all the possible vaccinations. The other thing we do is post-exposure prophylaxis. We have posters just about everywhere explaining if you do use a needle, what you have to do. We have a kit, an emergency kit, if somebody is worried, somebody who had HIV had potentially contaminated somebody else. We have this post-exposure kit. We also set up hygiene and hair care, and also nicotine substitutes, which you give fairly easily. Not boxes and boxes, but tons of this. Between pastils and patches, it's very rapid and it's as fast as you like, as much as you want. And to continue, we also have some focus groups, discussion groups. We have a dance group, a corporal expression group, and also what we have set up is these systems, is crack pipes. Perhaps maybe people not so much using injections now as crack pipes. We give about 40 per week. It's very high. Also give bicarbonate and aluminium. Nobody wants aluminium. They don't want it anymore. I didn't have much demand for that. We have naloxone. You can also give it not only on release, but during prison periods for people where we know that they're taking risks in prison. We can give them this naloxone. And of course, we'd need to train the staff as well as the prisoners, because if they are responsible for their own, if people have an overdose, then other people have to be able to come in. We've also set up this kit, an injection kit, that we give patients now from some 12 years. And the administration said that it's illegal, but we've been doing it for 12 years, and I think we have to do it because I can never be attacked for that. They know that I do it, but they can't get me for it because the law is there. The law is on our side. And that is where I have some difficulty with my colleagues who can't understand why in other prisons we can't have this kind of service. Why do you have this exchange of syringes? Because this is what people were using in 2014 from their own production, as it were. And when you see that, it's something which is totally unacceptable for any healthcare professional to see this kind of syringe, and even recently a syringe that we found with a patient, just to show you that at this level there must have been a leak in the syringe, and he tried to melt the plastic to block up the leak. You can see this is the needle, and it's been used maybe some 15 or 20 times, and there's still some blood that remains in the syringe. So you need to exchange material like that. No incidents over the last 10 years. And the administration says it's a weapon. I say weapons that are not syringes, but the weapons that I found are these. These are weapons that you can find in prison that prisoners have made to attack other prisoners. And this is what they use. They don't use syringes as weapons because they don't want to get caught. And it's they're not proud of injecting. They hide to do it. They don't show deliberately that they do use syringes to inject. So if they have somebody sharing their cell, sometimes they do it while the other person is out on his recreation time, or sometimes they do it in the toilets and they can hide to inject. We published what I said. We published a case study in all the international studies, the WHO bulletin, and what we've done. So we're always trying to talk about this because I think that today there's no reason why in French prisons, and I don't know about Belgian prisons and other prisons, there's no reason why we shouldn't have harm reduction in its complete form in prison. That's the latest publication where we talk about the example of Montpellier, where we don't have elimination of this, but in 6 years in prisons, if we were able to eliminate hepatitis C, is we were able to link treatment with harm reduction, and that limits infection. So that's how we've been able to eliminate hepatitis C. We look at certain prisons in Spain and other countries where hepatitis C treatment is given, but the reinfection rate is fairly high. When you have the syringe exchange program with it, you reduce the reinfection rate. So I just wanted to give you a last example, a patient who comes in, who do the serology just like everybody else. He was negative. 2 months later, he comes back because we know that he's injecting and he was positive. So we can become infected in prison. So that's a proof of infection within prison of hepatitis C. So there's a conclusion that harm reduction in prison is not an extra, it saves lives, it's health care, and it's a fundamental right guaranteed by the law. Thank you very much. So if you have any questions, thank you very much for the presentation. I just wanted to know, you looked about harm reduction equipment that you make available for the prisoners. I wanted to know where this equipment came from and what funding you have for that equipment. The funding, it's free, but in the framework of this availability, it's free. I had somebody who delivered syringes, but now it's an association called something Safe, and when I ask them for syringes, they deliver them. So when I ask for pipe cracks, they deliver them. Crack pipes, sorry, they're ready to help. Somebody will come and train you and make the material available for you and explain how you should use it. But it's free. You really don't need a budget to implement this policy. And if you buy it, it's maybe €1 or €2 for a kit. It's not a real problem. It's not going to make a hole in your budget. Insofar as the prison administration refuses to recognize consumption in prisons, how were you able to get them to agree for this analysis of wastewater coming out of the prison? The wastewater, they finally agreed because the French observance of toxicology or whatever, which is part of the European network, France was always one of the last countries not being able to respond to that question. So the European Observatory had all the big European capitals with wastewater except for France, and they agreed to do it for 3 prisons without giving their names. They didn't want to do it again because finding so much cocaine and heroin in the wastewater, we don't know who was consuming. It could have been the prisoners, but it could also be the prison staff. Maybe you can't say that most of the stuff is consumed by prisoners, but maybe not all. So I think that the problem today is that there's an ambivalence in the minds of our politicians that they know we don't need evidence anymore, but they say that if it's in prison, that if they're in prison, there's a good reason for it. As if in prison you should come out of prison clean with regard to how you went in. I think, however, they need to understand that you need health care. It is health care. So if there are no other questions, I'm going to ask Luis Patricio to introduce himself, and he's going to show you a little workshop. I don't know if you're interested. Luis has produced a kit, a little case, and in schools, when he does prevention, or in parties, or whatever, in street events, he can go around with this everywhere. And what he does is it's a prevention of addiction and so on. So, Luis, maybe you could say a few words about your little case. Thank you.
Thank you, Fadi. It's a surprise for me to be here with you. Fadi knows my kit, and that we use in Lisbon and Adrian as well. If you have Luis, if you look for Luis Patricio in Provençal, you'll be able to see this kit. And it's we started a few years ago. I'm a doctor and a psychiatrist, and I do risk reduction. I was asked to innovate. I made 15 proposals. The Assistant Secretary said that they would accept 9 of these. So 9 were approved, and we had to wait until 29 to have clean rooms. I'm going to take advantage of this to do some publicity. This is a calendar, a diary that we offer. In a few weeks, I'll be in Cape Verde. It's in Portuguese, of course. And this is how we try to start out. And if we go back over now, what's happening here? It reminded me the kit goes wherever it's invited. We can go from 4 years old to 90 years and above. You can touch everything. This, of course, depends on your target audience. And in Peru, they wanted to. We wanted to do this in Peru, and that they use with what they've got. They call it the mochila, which means a rucksack. If we work with children, for example, we can work with scissors. And for one child, the scissors is a game. For another, so this is adapted to each of the users. It puts an object in everybody's hands. When we start like this, you got the first card. This is for a teenage audience or young parents audience. And of course, you need to pass on this notion. Some of you say we're nuts, crazy talking about infectious diseases. One of the first gestures a mother would do for the child she loves is to get the child vaccinated to protect it. Giving it a medicine. These are, this is to try to reduce the mystification that exists around drugs, and try to push and to encourage responsibility, know-how. When we go to prison with the suitcase, firstly, we can have choose this responsible person in the same session. Somebody who is not capable of doing the session, they won't come. It reminds me of the 1980s, when I was invited into one of the largest prisons in Lisbon to provide therapy. We don't want to show objects which are copies of illegal substances. We've got the original of what is legal. If they ask me to talk about the usage, as my field is in reducing risks, we need to show our know-how, and there's also a technique not to do it. The same thing about sex. The question is, if you need to, without changing equipment, it's a very hard and explicit language, but when we, in prison, when you have 18-year-old children, or you may be 18-year-olds or 60-year-olds, so you need to adapt the message. And what's more interesting in prisons is the taste they have to be able to speak somebody who, a psychiatrist who's able to talk about this. The psychiatrist gives a prescription. We'll pass two of these round. You can imagine that this is interesting. Doesn't matter what the name is. Here would be an anabolic steroid with a quality stamp. The problem is when there are people who inject this,
Cooking oil.
but it may contain cutting oil. It may not be the real drug, so you have to not trust what's in it. You have to check. And by mistrust, we have to demystify. We need to demystify and try to share knowledge to make people responsible. But knowing what's happening around them. And something here that you may find interesting. Here you have a crack pipe. And what's the aim here? We don't know what's in it. This liquid was mixed in the room with something that had come from India, and the patient put the same thing in different packets, and the price is different. And for years, this was sold a commercial network of synthetic substances. It could be forbidden in some countries or not. In here, it was openly sold until 2013. If it's drugs, be careful. And there's a lot of psychotics that's appeared with this. He was so surprised. And this is what he did, and he actually broke his mother's arm by accident. So you imagine the mental charge, the strain that he was under. The Catalan risk reduction kit. Here you've got an excellent France. And you know, I went into a pharmacy a few weeks ago and said, do you know this? And they said, no, what is it? But if you go in the district where you find on injectors, it's not risk reduction in that case, it's theatre. I just want to show you one or two things. We've become an older country, but when you're trained here with you, because people have become an aged population, and what Fadi showed, this is how you create a crack pipe. Here too. The difference is when you do it with doctors, there's a lot of people who've never seen this who can't imagine it. Have you found out what it is? To touch it, you've got to put your hand in it. It's for to make to get other people to realize that we have these. We try to get people to work on the whole body, not just the liver. This is what I wanted to share. What's that? Can you imagine? It's Indian tobacco. When we play, we explain it. Atoms which make sure molecules are different. The substance is different. You can play around with them and add other molecules. Or atoms to create another molecule. If you have a substance which is damaging, if it's we don't let them do certain things with it. Thank you.
Merci, merci à Luis. Alors, Luis, il fait un peu le tour.
Luis has been all around Portugal. He's very happy. Thank you to all the speakers this afternoon.